would like to begin by acknowledging the Indigenous people of all the lands that we are on today. While we meet today on a virtual platform, I would like to take a moment to acknowledge the importance of the lands which we each call home. We do this to reaffirm our commitment and responsibility in improving relationships between nations and improving our own understanding of local Indigenous people and their cultures. From coast to coast to coast, we acknowledge the ancestral and unceded territory of all the Inuit, Métis, and First Nation people that call this land home. And I'd like to introduce you to Dr. Andrea Furlan. She is an award-winning pain specialist in Toronto, Canada. She is a physiatrist, I hope I'm saying that right, a specialist in physical medicine and rehabilitation. I'm sorry, I can't talk today. She holds a medical degree from the University of Sao Paulo and a PhD degree from the University of Toronto. She has 30 years of experience helping people with chronic pain to get better quality of life. She will be talking about her new book, 8 Steps to Conquer Chronic Pain, A Doctor's Guide to Lifelong Relief. You can order her book today through her website, www.drandreafurlan.com. I will also put that in the chat, and it's also in the daily email that you got from me today. So there's lots of ways to get this book, and we're so happy to welcome Dr. Andrea Furlan. I'm sorry. How are you today, Dr.
I'm
Furlan?
good. Thank you so much. Yeah, thank you so
So
much for inviting me to be here and talk to this group, amazing group that you have here. I never heard about this, but I will start recommending this to a lot of my patients and counties that I know and people that would benefit a lot from being part of this group.
Oh, please do. Yeah, I know when I started mentioning that you would be coming, there was a lot of interest here, and I think it maybe, no pun intended, hit a lot of pain points for people. So before we start, I wonder, how did you start getting into pain management? Of all the other things to do in medicine.
Oh, because it started even before I went to medical school. I think I was a teenager a long time ago, and soon I'll be able to join your group. And I was, during my teenage years, I had terrible menstrual cramps every month. And they were very debilitating. I grew up in Brazil. I moved to Canada 27 years ago. And I remember having to miss school and social gatherings and had to do exams, suffering pain because the painkillers, they worked for the menstrual cramps, but they detonated my stomach. So really, I had to choose between my stomach and my cramps. And I found that this was so debilitating. And then I decided to do medicine. And when I was in medical school, I was between neurology, rheumatology. I never heard about physiatry. And then when I heard about physiatry, which is the specialty of the person with a physical disability, I fell in love because the physiatry is a specialty that we help the person to focus on function. We treat disability, which pain is a kind of disability. It's invisible, but it's a kind of disability. And I remember in medical school, I saw a patient that we admitted her in the hospital because she had pain all over her body. And nobody knew what she had. And we invited a physiatrist like me to come and do a consult. And he did one session of acupuncture. And the next day we discharged that patient because she was pain-free, basically. Now I know she had fibromyalgia. And now I understand what happened at that time, but I didn't. So I decided to go into the medical, physiatry and pain medicine, because I saw so many people suffering and not a lot of people that know what to do with them. And it has been 30 years since I graduated from medical school, so a lot of years.
So tell me, how has pain management changed since you started 30 years ago?
A lot. So and I am a scientist too. I work here at UHN, University Health Network. I'm right in front of Sick Kids. Sick Kids is in front of me here. For those of you who know where Sick Kids is, my window there is pointing to Sick Kids. And so I work here. I'm a professor also at the University of Toronto. And just in these blocks here around University Avenue, a lot of things have happened in the last 20, 30 years that we had no idea 30 years ago. And a lot of this is because pain was not seen as a science. Pain has never been a focus of study on itself, because everybody thinks that pain is a consequence of another disease. Well, which is true, right? But a lot of people think, okay, we don't need to focus on pain. If we can eliminate the cause of the pain, then the pain will go away. Now we know that that's not true, and that's what chronic pain is. And I like to use the analogy of an alarm system. So I always talk about the alarm system, and it makes it easier for people to understand. If you install an alarm system in a house, you want it to go off when there is a smoke, a burglar, a break-in, a flood in the basement. That's what our pain system is like that. We have this pain system installed in our body to detect danger. So we have sensors in our skin, sensors in our muscles, in our joints, tendons. And those sensors then go to the nerves, they enter the spinal cord, and then the spinal cord sends to the brain the information. The brain has to decide what to do. And then the brain the brain will activate areas that will suppress that pain. That's exactly what the alarm system of a house does. There's those sensors in the wall. They connect via wires or wireless to a box on the wall. That box you can manipulate, you can turn on and off, you can enter passwords. And that box will communicate with an office, like the alarm company office. The alarm company office, they will decide what to do. Do I send the ambulance, the fire truck, the police to this house? Is this house at a danger? Is there a fire? So imagine that a person had a pain, like they had an injury, they had a tendon injury. Let's use the shoulder as an example, because I can show here in the camera, right? Imagine that they had a shoulder problem. So there was a tendinitis, a bursitis, something in the shoulder. That's similar to having like a fire in the house. And then the fire trucks came, they fixed the shoulder. So the surgeon or the physiotherapist fix your shoulder. 6 months later, you are still feeling pain in the shoulder. 2 years later, you are still feeling pain in that shoulder. What's going on? It's because the alarm system of your body became sensitized. The alarm system of your body keeps that memory of that pain. There's nothing wrong there, but the person continues feeling pain. So we need to fix the pain system. We don't call the ambulance, the fire truck, the police. If the alarm system of the house is malfunctioning, you call the alarm company. So I am the doctor of the alarm system of the body, which is the pain system. So you see, when the pain system is deregulated, you don't focus anymore on the knee, the back, the shoulder. You have to retrain the pain system. And that's what a pain doctor is. That's what a physiatrist we do. And to fix the pain system, I don't have a magic wand that suddenly everything will be fixed. It's a lot of steps. And that's why I wrote the book, because I want the patients to actually the first step of the 8 steps is retrain your pain system and learn about this. Because once the person understands that the pain became now the disease that they need to treat, they stop focusing. I need another MRI. I need another ultrasound. I need another X-ray. I need another lab test because I need to find where's the fire in my house. But there's no fire. You need to fix the alarm.
So tell us a little bit how you would go about that.
Fixing the pain system or finding what's wrong.
Okay. Okay. We'll start with your first step for conquering in the book.
Yeah, so the first step, which is retraining the pain system, also implies that we have to have a good diagnosis. Mm-hmm. So even the chapter before retraining the pain system means, what is the diagnosis of pain? Because there are 3 types of pain. If I don't explain to you what are the 3 types of pain, you're not going to understand what I mean with all the other steps, okay? When we say the person has chronic pain, where is the origin of the pain? So the 3 types of origins of the pain. The first one, and I'm sorry, I don't have better names. I have to say those technical names: nociceptive, neuropathic, and nociplastic. Okay, nociceptive means that there is a fire in the house. Okay, so there is a fracture, there is a injury, there is an inflammation, so a gout attack. Some people have gout. Gout is an inflammatory arthritis that you can see the gout, you can see the joint inflamed, red, swollen. So that is nociceptive. You need to remove that inflammation and then the pain will go away. After the inflammation is reduced, the pain goes away. Now imagine that the gout is nociceptive, which means the alarm system is perfect and it's only doing its function. It's alerting the brain that something is wrong. Now imagine that the gout happened in this joint here. It was swollen and red for a couple of weeks. Now it's fixed. There's no more crystals inside of the joint. But 2 years later, 5 years later, the person is still feeling pain in this joint. That is because now this joint now is sensitized. So the pain system is abnormal. That is nociplastic, the third type, nociplastic. Now, neuropathic pain means there is a lesion in the transmission of the pain. So the nerves or the spinal cord or the brain, there is an actual lesion in those structures. I'll give an example. If a person has diabetes and they have the diabetes destroyed the nerve endings. Sometimes the diabetes causes a disease called diabetic neuropathy, which means the nerve endings in the hands and feet are not functioning well. It's not that they are destroyed, they're just not functioning well. And the person have numbness, tingling, and weird sensations in the hands and feet. So that's because the nerves are not working, the sensations are not being transferred properly. So that's neuropathic. So nociceptive is if there is an injury, we can see there. Neuropathic is a problem in the transmission in the nerves, or people who have neuropathic can also be herpes zoster, shingles, postherpetic neuralgia, trigeminal neuralgia, because there's a nerve that is being compressed. Multiple sclerosis that destroys the myelin around the nerves, spinal cord injury, stroke. So those are examples of neuropathic pain. And nociplastic is when those things have resolved, the first and the second have resolved, but there is still that malfunction of the pain system. Is that okay if I continue?
So good. Yeah.
So,
listen, everybody, we will answer the questions at the end. So I know some people
your questions, yeah. Keep notes of your questions.
You can put them in the chat now, but we'll get to them after we talk. Okay.
Yeah.
Sorry.
So when a person presents with chronic pain, the first thing we want to see as the doctors, the physician, is the diagnosis. What kind of pain this person has? Is it more nociceptive, neuropathic, or nociplastic? Or it can be a mix. Sometimes they have all three, or they have two of three. If they have of course, if they have nociceptive pain, we'll try to fix the cause of the pain, and the pain will go away. An example is people who have arthritis of a knee or a hip. And you can see that their hip or knee is destroyed. You put a new hip or a new knee and the pain goes away, which means that, it was just that body part. Now, fibromyalgia, if you heard about fibromyalgia, is nociplastic pain, is the third type of pain. It doesn't mean that they are imagining the pain. That's not what I'm saying. I feel so sorry for people with fibromyalgia because they hear doctors telling them, oh, you must be imagining this is in your head. That's not true. There is a problem. The problem is not in the knee, the low back, or the feet, or the shoulder. The problem is in the pain system. Mm. So fibromyalgia, they have pain all over their body, and we need to fix the pain system. So we need to find out what is the type. Is neuropathic, nociplastic, nociceptive? So if we diagnose that they have a component of nociplastic pain, which is the last one, the pain system, nociplastic, because it's plasticity. Have you heard about neuroplasticity? Mm-hmm. Neuroplasticity or bioplasticity is a wonderful thing. It's what makes us learn. Plasticity means our brain, not only neuroplasticity means neurological plasticity, but we have bioplasticity. Every tissue of our body, skin, bones, muscles, they can modify, they can learn new things, okay? That's why this pain is called nociplastic, because there's plasticity involved, which means that now the body is sensitized and has learned this pain. And this pain is almost like a memory, but it's real. The person feels pain, and it's horrible because they feel pain all the time. But we need to basically retrain the person. Some people say unlearn the pain. It's really hard to unlearn something that you learned. Like if you learned how to play piano, can I teach you how to unlearn how to play piano? Probably not. So unlearning pain is a concept that I don't like to use, because I think it's impossible to unlearn something that you learned. Now you can substitute that memory with something else. You can teach the person other things. So how do we do brain retraining? How do we retrain the pain system? How do we fix this pain system? Since we cannot erase what they learned, we can teach them new tricks that will replace that memory. And one of the things that we use a lot is exercise for the mind and exercise for the body. So I love that your programs involve morning exercises for the body, like Pilates, I saw that, yoga and Zumba. That is amazing, because we use exercise when a person is moving their body. They are, of course, exercising the muscles, the bones, the tendons. But did you know that when you're exercising your body, you're also sending messages to your brain and retraining a lot of synapses, retraining a lot of areas of your brain that are reconnecting, they are making connections that are extremely important, especially to fight pain, chronic pain. Let me give you an example. We have an inner pharmacy in our brain. It's a powerful pharmacy. It's actually not in the brain, it's in the brain stem. So the brain, I don't have a figure here of a brain, but the brain is here, and we have like a stem holding the brain. That's called the brain stem. So in this brain stem, that is right below here, almost, in the close to the neck, right above the neck, we have a lot of cells that they produce pharmacos. They produce powerful opioids. They produce dopamine, they produce serotonin, they produce cannabinoids. So let's talk about each one of those. And exercise is what opens the door of this pharmacy. Okay, exercise opens the door of the pharmacy. Acupuncture work opens the door. That's why my patient that I told you, when I was in medical school, we did acupuncture. We opened the doors of this pharmacy. She released a lot of all of this. Opioids, serotonin, cannabinoids. She was good for a week. And probably, I don't remember what happened to her after, but that's what happens. When you open the door of the pharmacy, they have flush of medications that do not cause side effects, do not cause addiction, do not cause overdose. Isn't that wonderful?
Yeah.
Okay, so let's talk a little bit about this pharmacy that we have inside of our brainstem. Opioids. You heard about opioids. Who has not heard about opioids, right? It's in the news, people die of overdose. We produce many types of opioids in this pharmacy. They're called endorphins, dynorphins, enkephalins. And endorphin is 100 times more potent than morphine. And you only need tiny, tiny, tiny milligrams. So your body knows exactly how to release. It doesn't release more or less. It releases the right amount that you need. Okay? Another thing that opens the door of this pharmacy is mind exercises. We know that people who meditate, and when I say meditate, just doesn't mean like 5 minutes meditation and that's done. It's deep meditation. People who learn how to do deep meditation, they are able, in the beginning, they need half an hour, maybe 1 hour, but then they learn and they might be able to do this in less minutes. They become more efficient. They can also really, we know this because we can measure the substances. It's amazing, we can measure, right?
Mm-hmm.
So opioids is one of the things that this pharmacy opens. The other one is dopamine. So dopamine is the pleasure neurotransmitter, is the one that, when you do something good, if you do, if you have a pleasure, if you eat a nice meal, if you do something good and someone says, oh, good job, you have a release of dopamine. That's what makes people get addicted to pornography or shopping, addicted to gambling, because when they're gambling and they get that, a little bit of money, they release dopamine in the brain. That's why people get addicted to opioids, alcohol, drugs, because they have peaks of dopamine. So we can open that pharmacy, inner pharmacy, with exercises, meditation, distraction, music, laughter, anything that we do that enjoy. The other substance is serotonin. So this brainstem can also release serotonin, which is the antidepressant. People who have low serotonin, they feel low mood, depressed, sad. So we can have the happiness neurotransmitter. And the last one is cannabinoids. You probably heard about cannabis, marijuana, THC, CBD. This come from the plant. So the marijuana plant, produces THC, CBD, and another 100 cannabinoids. Our body produces cannabinoids. And we have receptors for cannabinoids in our body. One of these cannabinoids is called anandamide. And anandamide is wonderful because it does the same thing that THC does. So we can open the door for cannabinoids. So basically, exercise, you can open the doors of that thing. So that's one thing we use for retraining the pain system. Because in people who have chronic pain, we can test this in laboratory. Believe it or not, there are people who come and they're volunteers. Can you believe that there are people who volunteer to come to the laboratory to suffer pain?
Wow.
That's another story, right? But they do. And these can be healthy volunteers, but these are also people with chronic pain. They go to the laboratory to be tested. So they provoke pain, and then they measure, can you release, can you open the doors of this inner pharmacy? And in people who have chronic pain, especially fibromyalgia, migraines, chronic low back pain, even arthritis, they don't produce a lot of these medications. We can see they don't. They are very deficient in producing this inner pharmacos. And now we know that you can retrain this inner pharmacy to start doing it again. So with training, and that involves mind exercises, body exercises, they are able to improve. So that's one of the things that we use to retrain the pain system. The other thing that we need to retrain the pain system is the emotions. We know that pain is not just a sensation that, activates an area of your brain, tells where it's hurting. It's more complex than that. When a person is feeling pain, now it doesn't matter if it is nociceptive, neuropathic, or nociplastic, doesn't matter. Any pain will always activate many different areas of the brain that will overwhelm the brain. That's why they can't concentrate so well when they are in pain. That's why they can't sleep so well. That's why, because they are also fatigued during the day and insomniacs during the night. They're irritated. It's because they're always kind of in a hypervigilant state. Mm-hmm. If they feel stressed all the time, they feel overwhelmed, because all of those areas of stress are being activated. It's almost like their brain is saying, you're in danger, you're in danger, you're in danger all the time. So your brain becomes overwhelmed. Who can be in danger all the time? And you basically, say, I give up and I can't think anymore. So we need to, part of the brain retraining or retraining the pain system is deactivating those areas of danger. So we need to retrain the brain to learn that they are not in danger. I know you're feeling pain in your knee. I know, we know your pain is real, but the orthopedic surgeon already looked at your knee. Everything is okay. You don't need surgery. You don't need injection. It's fine. You can move this knee. So we teach the person to start moving that body part. We don't want them to suffer pain. We don't want them to, be strong and suffer through the pain. No, we want them to change how they interpret that pain sensation, that it's not dangerous anymore, because that is the alarm system that is going off in the brain. And it's amazing because once they learn, okay, I'm feeling the pain, I'm still feeling, but I'm not afraid of this pain anymore. I know this is just a sensation that, the doctors are confident that they have nothing else to do here. Don't need another MRI. I don't need another injection. I don't need surgery. It's just a sensation that I'm feeling. And then you see those areas of the brain kind of deactivating. And the less emotions they have in that pain, guess what? They feel less intense pain. It's amazing. You see, I'm passionate to talk about this because I've seen a lot of people succeeding, conquering their chronic pain with those simple things.
It's very interesting. I can see the correlation between anxiety and that as well, because there's the same, as you said, the alarm system is always going off, and it's just trying to figure out how to manage that.
Yeah.
So I'm sure you see both of those things at once. So tell us, okay, so we've got the mind interventions that we're going to do, some mind therapies. You talked about, there was one, and I will put this in the chat, everybody, but Dr. Furlan has an amazing YouTube channel with many different videos talking about very different topics about chronic pain and other things. And I have linked that in the daily email, and I'll also put it in the chat. But Dr. Furlan, tell me about why self-compassion you find is so important when you're managing chronic pain.
Oh my God. Yeah, that is such a big topic.
Mm-hmm.
Self-compassion, it's different. I talk about self-love, self-compassion, self-help, self-management. This is the key for conquering chronic pain, because I cannot do this for the person. Mm-hmm. I cannot do this for them. When I have a patient in front of me, I wish I had a magic wand that I could do, or a pill that I could prescribe, and they have to do this for themselves. And self-love, self-compassion, self-management means that they will understand what is chronic pain, the disease that they have, and then they will do an inner look at themselves. Sometimes they need a counselor, sometimes they need a psychologist, a social worker, psychiatrist to help them to do this with themselves, because most people don't like to touch those parts of their body. When I say body, our body includes this physical body and our mind or emotions. I can't separate the body from the emotions. A lot of people like to talk about their body, what's wrong with the tendons, the bone results, or the blood tests, but they don't like to talk about their emotions because it hurts. They don't like to talk about what happened to them in the past, childhood, or how angry they are, or how frustrated they are, or how lonely they are, because that is uncomfortable territory. Now, I can't separate the mind from the body. And if the mind is suffering, the body will suffer. So self-compassion, self-management, self-love means going to those areas. It means being open to talk about those things, even if it feels uncomfortable. So self-love does not mean you go to a spa and you spend the whole day doing manicure, pedicure, your hair, and perfume and aromatherapy. No, that's not self-love. Self-love means loving yourself deeply to the point that you're going to open up with someone like a professional, seek professional help, and open up your emotions, your traumas, because until we break that cycle, I can load you with tons of medications and give you tons of prescriptions. We're going to go nowhere. If that emotion, if that trauma, if that frustration is not being properly handled. But that's basically, it's tough to hear. Because some people think that I'm saying your pain is in your head, you're imagining this, it's caused by psychology. That's not what I'm saying. What I'm saying is that they come together and they feed each other. I was in a meeting this morning and I loved someone put a sentence and they said, fear is the fuel of pain. I love that because fear, if you don't face your fears, fear of death, fear of cancer, fear of being alone, fear of being abandoned, fear of financial strains, fear of losing your job, fear of your kids not talking to you anymore. It's the fuel of pain because again, those fears will activate the danger signal in the brain.
Yeah. It is so, everything is so connected, so very interesting because as you said, like, and probably when you started in this research, pain was seen as you said, just a symptom of something wrong.
Yeah.
But now it's, as you've explained it, it's a whole management system, mind and body.
And diet. Can I talk about diet?
Yeah, please tell us.
Oh dear, because I love, I love when I see the person as a whole. When the patients come to me, because I am a tertiary pain clinic, so I saw patients this morning and they already saw probably 20 different doctors. And when they see to me, they are in pieces and they are still in pain. And I always ask them, what do you eat? How is your, what do you eat? Do you cook? How does your diet, what does it consist of? And again, remember that inner pharmacy that we have in our brain. If you want your pharmacy to produce endorphins, serotonin, dopamine, cannabinoids, and many other things, you need to provide the substances for your pharmacy to work. How can I expect, let's say that I open a pharmacy on the corner here of University and College Street and expect the pharmacy to produce medications, but I don't give them the chemicals. I say, okay, you're going to sell medications, but I'm not going to give you any chemicals. You have to make it from garbage. A lot of my patients, a lot of them, they eat junk in and out all day. It's because it's cheap, it's easy, it's affordable. They tell me that sometimes they are alone and they don't have anyone else to cook for. So it's easy for them to, they eat chips and pops. And I say, oh my God, how are you feeding your brain? How do you expect your brain to produce your own endorphins and serotonin if you're not giving fruits, fibers? Fibers are so important for our guts. In the last 20 years, we know that the bacteria that grows in our guts, they kind of regulate the functions of the brain. Actually, the bacteria in the guts produce a lot of serotonin, although they're not actually used by the brain because the serotonin produced by the bacteria in the guts don't cross the barrier, so they don't enter the brain. But anyways, it's a lot of serotonin that is produced. The bacteria in the brain communicates with the immune cells, and the immune cells bring this message to the brain. There's a lot of talk between this brain and the guts. If you don't feed this bacteria with fibers, with good food, nutrients, you're going to grow bad bacteria in your guts. We know now that depression, people who are depressed, they have a different composition of bacteria in their guts than people who are not depressed. I don't know if you heard about this, but I was at a conference, a pain conference a couple of months ago, and they were talking about pills where they put believe it or not, stools of people with a healthy bacteria, they put inside of the pill and the other person swallows and they improve their mood. Okay, I don't know if I want to prescribe that kind of pill, but it's called the fecal transplant. But it solves the problem because first, what they do is first they give antibiotics to kill all the bacteria that this person has in their guts, and then they give this transplanted from another person's stools, and then it grows that healthy bacteria, and the person improves pain and mood. Anyway, so that's a new type of treatment. But for you to see how important it is what we eat, the kind of food, the nutrients that we give our body, because if you don't give the good nutrients for your body to produce good muscles, so you have to feed your body with proteins because you need muscles. You need vitamins. Vitamin D is extremely important for pain and mood and sleep. You know, serotonin is made of tryptophan. So if you don't eat foods, tryptophan is everywhere, but bananas, they're rich in tryptophan. So omega-3s are very, very essential for the functioning of our pain system because they are anti-inflammatories. So again, nutrition is extremely important if you want to fight. So one of the steps in my 8 steps is actually, let's talk about what you eat. The other one is sleep. Another step is, let's talk about your sleep. Because I had patients that they have a horrible sleep routine, totally out of whack. They take a big nap in the afternoon. They sleep whenever they want, when they feel like. They don't have a routine. They don't have good sleep hygiene. How do you expect your brain and your body to function well if you're not pay attention to those things?
Yeah. And then I understand that all the steps are very holistic. So you can't work on one thing, you have to work on them all at the same time. What are the other steps? Maybe just quickly summarize them, then we can get into some questions before we.
Yes, of course, one of the steps I talk about is medications, because we do use medications, especially when the pain is neuropathic, like that nerve pain. If the person has shingles, diabetes, multiple sclerosis, then we enter with some medications like antidepressants, anticonvulsants. If they have an inflammation like gout or arthritis, we may use anti-inflammatories. And we might use opioids in a minority of cases if the person needs opioids. I'm not against them, but it's not for everybody. So one step is we talk about medications. The other one is about exercises. And I explain why exercise is important. Why do we need to do this? It's not exercise just for the muscle, but it's exercise to retrain the whole pain system. The other one is emotions, as I mentioned, controlling your emotions. One of the steps is also the social aspect of pain. Because we know, and your group is amazing by doing this, because we know people respond differently depending on the social context. And we know this from laboratory. You bring people to laboratory. I'll give you an example. You bring people with chronic pain to a laboratory, and you bring their spouse or partner, and the spouse or the partner is holding their hands, is calming them down, and then you start provoking pain. And then we ask them to give a number for this pain. From 0 is no pain, 10 is the worst that you can imagine. So they give numbers. They give low numbers, lower. And then we bring them back to the same people we bring to the laboratory. Now they don't bring anyone. There's nobody hugging them, nobody calming them down. And we start showing them pictures of strange people, people who are, making faces that are angry. So you change the social context. You change what is around them, and you give them the same painful stimulation. It's the same. Guess what? They report much higher levels of pain. Just changing what is around us. We didn't change, the pain is the same. The stimulation is the same. So we know that depending on who is around us, how we feel, like a child who is feeling pain, that is hurt, if the mom is close and the mom comes and kiss your boo-boo, put a band-aid, go keep playing, and the kid is in the playground, immediately the pain is gone. Does it mean that they may have a cut? The cut is still there. It's still bleeding. But the mom kissed boo-boo, said everything is going to be around. Their friends are playing. They don't feel pain. Now, if that kid doesn't have mom around, is alone, feeling frightened, let's say in a war zone, maybe that kid had the same cut, but now, they are in Ukraine and they saw their mom dying and they have no one to help them, no one to kiss their boo-boo, no kids playing. It's all bombs and bombs and bombs. Their pain is going to hurt for years. You see what I'm saying? So the social context around what's happening at the time that you have pain is extremely important. So I talk about the social, that's one of the steps. And the last step is about how a person with chronic pain, they can set goals for their life, how they can conquer the mountain, how they can, express their emotion, how they can communicate their pain with their family, their doctor, their co-workers, their manager, because people don't know how to talk about pain. Sometimes people hide their pain because they don't want anyone to feel sorry for them. So I teach them about how you communicate using proper words at the right time. Some people also communicate a lot, so they're always complaining. Nobody wants to be around them. So we talk about this and helping them to live a good quality of life, because sometimes it's impossible to remove the pain, but it's very possible to live good quality of life.
I could see that. I mean, I could see pain being very lonely for people, especially with chronic and you're not sleeping very well, you don't feel like being social.
Yeah.
And maybe you're homebound. There's
Yeah.
a whole bunch of different reasons why that could be isolating. Okay, those are some great steps. So I will put in how to get Dr. Furlan's book in the chat. Now we will open up to a few questions here. I know there's a few things in here.
And please remember that I cannot do a consult for your pain.
Yeah, there'll be no consult. Lawrence wants to know what the difference between an occupational therapist and an osteopath.
Oh, good question. Yeah. An osteopath, we don't have a lot in Canada because they are not regulated profession in Canada. In the United States, the osteopath are at the same level as a doctor, medical doctor, but here in Canada, they are not recognized as doctors, but they do a training that is equivalent to medicine, medical school in the United States. An occupational therapy, they're not medical doctors. They do training similar to physical therapists. So they do university degrees, and the physiotherapists focus on, the joints, like the exercises of the major joints, physical therapy exercises, and the occupational therapists focus on also exercises, but in terms of a function. So they want to rehabilitate a person to regain something that they lost. So I'll give an example of a stroke. If a person has a stroke, the arm is paralyzed, the occupational therapist will help them to do some adaptations, maybe to do some splints, so they can use the paralyzed arm maybe to move a mouse. The physical therapist will help them, with stretching and strengthening of the shoulder, the muscle, so they can regain muscle power. So usually occupational therapists and physiotherapists, they work together in the rehabilitation team.
Okay, great. Somebody was wondering about the phantom. This must have been when we were talking about the different kinds of pain, the phantom pain, so like a phantom limb. So that would be something that we were talking about. Yes.
Yeah, phantom limb pain is, for those of you who don't know, is the person has an amputation, and it could be an amputation of a hand, a foot, a leg, or also amputation of a breast, amputation of a tooth, amputation of prostate. So anytime that people remove, the surgeon remove a body part, that's called an amputation. people may have a pain in the breast that doesn't exist anymore. That's called phantom pain. So because the limb doesn't exist anymore, if the hand is amputated and they continue feeling pain in the fingers, it's clear there's nothing wrong with the finger. This is not plastic pain. So it's the third type of pain.
Okay, great. Lynn says, how do you get rid of nerve pain? I've had neuropathy for 5 years. I take gabapentin a day. It is miserable. Obviously we can't do individual consults here, but I would
I'll talk,
imagine
yeah, I'll
nerve
talk in
pain.
general terms.
Okay,
Because,
great.
yeah, I don't know all the details of each patient, each person here. But nerve pain, the neuropathic pain. So remember, this is again a nerve injury. Like there is, we can see where the nerve injury is. We can measure, like we do some tests called electromyography, nerve conduction studies. I know this is a torture test, because we have to do electrical shocks and poke needles. I'm sorry for those things, but that's the way we can test the nerves. And we know where the injury is. So the treatment for nerve pain, first of all, is if we know what's causing the nerve pain, try to eliminate that cause. If it is shingles, like I had shingles 4 years ago. Yeah, 4 years ago, I had shingles on my leg. And fortunately, I was diagnosed within 12 hours because I saw the blisters in my skin and I said, oh, this is shingles. I went to my friend right away, started getting the antivirus medication. So if you know that your neuropathic pain is being caused by a nerve injury, a virus, the shingles, for example, get the antiviral. The sooner the better, because then you kill the virus and the virus does not destroy the nerve, right? If it is diabetes that is destroying the ends of the nerves, make sure that your blood sugars is well controlled. If it is alcohol, oh my God, alcohol is a major cause of neuropathic pain. Quit drinking alcohol, stop, because alcohol destroys the nerves. If it is vitamin B12 deficiency, a lot of people have neuropathic pain because they are deficient of vitamin B12. Make sure that you get vitamin B12 supplements or injections. Now, if you had a nerve pain, neurological pain, neuropathic pain, and it's gone, you cannot treat the cause of that pain anymore. You are left with that pain, the residual pain, the chronic pain. The treatments that we have include antidepressants like amitriptyline, nortriptyline, duloxetine. They also involve anti-seizure medications like gabapentin, pregabalin, carbamazepine. They also involve opioids. Sometimes we have to give like morphine, hydrocodone, tramadol, or we can give them cannabinoids. Like even, I don't recommend people smoking cannabis, but we have tablets. Nabilone is a tablet that is paid by the government of Ontario. It's called Nabilone, and that mimics what the THC would do in the body.
Okay, great. Lots of good suggestions there. What else we got here? Does your book have specific exercises?
So the book has QR codes to my videos of specific exercises. So I don't know if you have it there. Let me see. But
I did. Yeah, I have it on in the chat too. Yep.
so this is the book, and then so you can find the chapter of exercises has things like this. So this is called a QR code. So if you have a cell phone, or I think only cell phone can read QR codes, you go with your camera, and then it shows links to the video. I have a lot of videos of exercise in my channel, and people have difficulty to find them. So I put the QR codes in the book.
Oh, nice. Okay.
I have exercise for osteoporosis, exercise for low back pain, for neck pain, for shoulder, knee, hips, ankles, elbow, hands, almost every part of the body.
Yep, you cover them all. And you have over 30 million views, I see. That's a lot.
45 million views.
Oh, sorry, 45 million. That's amazing. Which you can see how helpful that they are, guys. So go check out her channel for sure. Okay, what else we got here? If there's more than one reason for the pain, what is the best approach?
Yeah, good question. So I try to eliminate first the one that would be like the low-hanging fruit there. If the patient has a nociceptive and nociplastic pain, if the nociceptive pain is easy for me to eliminate, like it's an inflammation of a joint, and I know that if I give them anti-inflammatories or apply ice, that will help that joint. I think I'll do that first. Sometimes it's a muscle pain, and I do massages and I tell them to apply hot packs. But they will not get when they come back to me, they will say, oh, I'm better, but I'm not, it's not better the way they expected. Like some people expect all their pain go away. So I tell them it's because I only treated one type of your pain. We still have the other type, the nociplastic pain. The nociplastic pain takes longer sometimes because they need to start doing exercise for the body, exercise for the mind, but it's the most rewarding. I love when a person eliminates the nociplastic pain, because then it's also so easy to treat the other kinds of pain. I tell them, if we eliminate this nociplastic pain, I can see now where is that little fire in the house. It's the same thing of the alarm system of a house. If the alarm system of the house is malfunctioning and it's making noise very loud, it's hard for me to find where's the fire. And sometimes the fire might be this tiny, but in the middle of all the noise, I can't even find the fire. The fire may be just the size of a match, right? And but if there's too much noise, yeah, sometimes we do both at the same time. I give the person exercise for the mind, some books for them to read, videos to watch, or when it's really severe, when I have patients that have a long history of psychological trauma, people who have PTSD, post-traumatic stress disorder, or they have severe depression, severe anxiety, that will take longer because they need to have counseling, psychotherapy, and that will take longer. But if it's not that severe, it's very rewarding, and they would be able to do this in a couple of months.
Okay, this seems to be very specific, but somebody wants to know about complex regional pain syndrome. What
Yes,
is the
CRPS.
medication that doctors use most in Canada?
Okay, CRPS, yeah. For those, I have a video that I explain what is CRPS, because it's a rare disease. It is a type of chronic pain that happens, and CRPS usually affects the extremities. It doesn't affect the trunk, for example. It's more the hands or feet, and involves a lot of sympathetic drive, which means the sympathetic nerve system is activated. So you touch their skin, they're very painful. They have some swelling, redness, changing color, changing temperature. And those kind of pain activate the emotions very strongly. So the person is extremely anxious, extremely depressed. It's part of the syndrome. In terms of medications, medications only does not treat CRPS. We do need medications plus psychotherapy plus exercises. So the three combined is essential. And the type of medications include usually antidepressants and anti-seizure medications.
Okay, great. Denise wants to know if the same responses work for chemotherapy or radiation pain.
Pain after chemotherapy and pain after radiation pain. Yeah. I don't see a lot of people in my clinic with this kind of pain because they're seeing in the other building of UHN, they're seeing the Princess Margaret Hospital. I have colleagues that they work in the pain clinic only with people who had cancer, chemotherapy, radiation. We tend to use the same approach. You see, because radiation chemotherapy usually cause damage to the nerves, so they cause some neuropathic pain, but they also cause nociplastic pain because of all the fear of the pain itself. And in people who had cancer, every time they have pain, the first thing that they have is danger, danger, danger. This is the cancer coming back. It's the metastasis. So their danger alarm is extremely acute. So we do need to calm down this danger alarm, because if the danger alarm is very intense, they will feel more pain. The pain will be more intense. And remember this, we now know from a lot of research that the intensity of the pain that the person has is not proportional to the amount of damage. Let me say that again. If a person is feeling a lot of pain, my pain is very intense, it's 10 out of 10. Therefore, it must be a really bad cause, something really harmful. No. The pain can be 10 out of 10 and you have this tiny harm, or in other case, you have a big harm and no pain. Example is some people have a heart attack, which is a big harm, and they don't feel any pain. You probably know someone who had a heart attack and had a tiny pain. Or the other example is, people who have a stroke and they don't have any headaches. Stroke is a big harm in the brain. A lot of areas of the brain dies for lack of oxygen, and they have no pain. So the amount of pain is not a good thermometer of how much harm. A lot of people think that, that it's a good thermometer, but it's not.
Very interesting. Okay, this question is interesting too, and we get this a lot every day. What if the hips and knees and shoulders hurt too much and it's too painful to exercise?
Yeah,
You do it anyway?
I know. Yeah, I'm not a proponent of being strong and work out through the pain and be stoic and suffer pain. I'm not proposing that. When it's too hurtful to do exercise, we can do injections in the joint to alleviate the pain. And so those injections, they may last, 2, 3, 6 months, and then you can build your muscles while your pain is less. You can also take some painkillers before you do exercise. So you don't need to go to exercise, suffer, come back home, and then you take the painkillers. You can take the painkiller before you go. It can be acetaminophen, plain Tylenol, and or we can modify the exercise. I had people that they just started doing exercise in the water, just, go in a pool, warm pool that covers most of their body, and they start doing exercise in the water, and they say, I don't feel the same pain that I do exercise outside of the water, and they can build up their muscles, their joint, because motion is lotion. And if you stop doing exercises, you're going to accelerate the arthritis. So it's not good to stop doing exercises. You need to do, but you don't need to suffer and, go through the pain. I'm not pro torture. I'm not here to say, you need to suffer pain. I am, let's do everything, keep moving, and if possible, with the least possible pain.
Right. Okay. Well, our time is up. Thank you so much for taking this hour to spend with us and talk to us. And I've learned so much about the whole pain management system. Hope everybody did as well. I know there's a few more questions left in the chat, but I believe if you buy the book or you go to her YouTube channel, you will be able to see lots of exercises. Somebody just asked what you do if you can't afford access to the types of exercises we require. So there's lots of free resources out there for that. So anyway,
most of these exercises can be done at home. The exercise that I recorded in my video, I did at home, and I do demonstrations at home with very minimal equipment that you need. And I believe your exercise that you also do in the morning, you don't need to pay anything. They are free.
You can come and join Art Your Service, and you can get extra.
I will recommend a lot of people to your program.
Fantastic. Well, thanks so much, Dr.
Thank you very much. It was very informative.
Yeah.
Thank you very much.
Okay.
Thank you.
Very interesting. Thanks.
Thanks so
Buy
much.
the book. Thanks very much.
Thank you, Jen.
Thank you so much.
Jen.